All right, we are ready to go.
Okay. Well, everybody, welcome back to Grand Rounds. Today, I don't need to ask you to sign the attendance record, but I believe that Sally may be sending out a program evaluation, and if you could fill that out and just send it back electronically, that would be great. The CME committee would greatly appreciate that. Today, it's my pleasure to introduce Dr. Edward Bottei. Dr. Bottei is an internist and a pulmonologist critical care specialist. He did his residency and fellowship at the University of Chicago, and then he went on to the University of Cincinnati, where he did a toxicology and hyperbaric medicine fellowship. And since 2002, he has been the medical director of the Iowa Poison Control Center, and he's also been the state medical toxicologist at the Iowa Department of Public Health. And he is also adjunct clinical assistant professor at the University of Iowa and at Drake. And the CME committee is very, very pleased that he was able to be the inaugural speaker here at our first virtual Grand Rounds. And so virtually, please join me in welcoming Dr. Bottei.
Thank you, and good morning. If at any time there are any questions, I believe there is a chat function that you can send them in. I have no conflicts of interest with regard to this presentation. And for the objectives, we're going to be talking about the common urine drug testing kits that we all know about, talk about their limitations, and then go into how comprehensive or confirmatory testing is done. Before we start into that, I'll tell you a little bit about the Poison Center. As already mentioned, I've been here at the Poison Center for 18 years. And the Iowa Poison Center, this is its 20th year for serving the entire state of Iowa from Sioux City. The 800 number that you see listed there, 800-222-1222, is a national 800 number. No matter where you are in the country, and including places like American Samoa, Puerto Rico, Alaska, no matter where you are, if you dial that phone number, you will be routed to your Poison Center. It works 24 hours a day, 365 days a year. And when you dial that number here in Iowa, you'll be talking to one of our pharmacists or nurses or one of the physicians, all of whom have specialty training in medical or clinical toxicology. Unfortunately, drug overdoses have become the #1 cause of injury-related deaths in the past few years. And a lot of that, of course, had to do with the opioid crisis. And while we deal with a lot of overdoses and poisonings and therapeutic errors, we also deal with a lot of other exposures too. So you see there is a snake and a mushroom, so we deal with natural exposures to things in the outside. We just had a snake bite about 3 weeks ago that we were consulted on. And of course, when children get into plants and mushrooms, we'll take those calls. We do occupational and environmental consults, also know a fair amount about drug lab testing, deal with recalls and nuclear, biological, chemical, radiological preparedness. The Play-Doh that you see there, we actually did a study looking at how much salt is in homemade Play-Doh. And it turns out that there's anywhere between 3 and 6 times as much salt in homemade Play-Doh as there is in the commercial variety. All of the data that we get goes into a real-time surveillance system that, as you can see, goes from the Poison Center to the American Association of Poison Control Centers, down to the state of Iowa, off to the CDC, the FDA, and various other government agencies. And studies have been done that have shown that definitely calling poison centers are beneficial, both with regard to the economics of it, saving the healthcare system money, helping get patients out of the hospital more quickly when a poison center is called as opposed to when they're not, and on top of it, saving money, as you can see there. So let's start with a 45-year-old woman who presents to the clinic with the complaint of being weak and dizzy. She came to her oncologist's clinic with this complaint, and you see her past medical history is diabetes, seizure, hypertension, and she went to the oncologist because she has metastatic breast cancer that's metastatic to both bone and lung. Her complaint is that she's not feeling well, even though she's very eloquent and speaks well, she doesn't have any more better description. She just feels blah and has been having trouble walking for the past week. She has fatigue, dizziness with walking, but the rest of the review systems is fairly unremarkable. And importantly, she hasn't had any change in the bone pain that she has from her metastases. In the workup, they sent off a urine drug screen. And as you can see from the 8 panels that were tested, it's positive for PCP, tricyclic antidepressants, and THC or marijuana. So what kind of drug screen was this? These are examples of what you'll see with the point of care testing or the rapid urine drug testing. You see them here. You've got on the left side, you've got 3 pictures, the cup, the strip holder, and then the strips underneath. That is one set of way testing is done through testing strips. And you'll notice in the cup on the upper left that you have 6 strips in there, but you also have slots for other strips. So you can put as many strips into that cup as the cup will hold and use that for the drug testing. The dip form, which is in the upper center, you see it has 5 strips. Usually they're no more than about 6 because it's hard to get those strips down into the cup of urine. So that's the strip method of testing. Then you have the cassette method, and you see you have 2 cassettes there. The one at the bottom has, you'll notice that there are 4 little wells that have drops right above them, and that's for putting drops of urine in, and then it will diffuse across and you'll see a result that way, and that's read by people. Whereas the upper one is a cassette that goes into a machine reader, and it doesn't, you'll notice it just has that the green arrow, it doesn't have specifically listed drugs that it's looking for, because once the urine's put in there, the machine does all the work. So this is the kind of test that this lady had done. Turned up with those 3 positives. When you take a review of her medications, it turns out that she's taking alendronate, has a fentanyl patch for the bone pain, and sublingual fentanyl spray for breakthrough pain, ibuprofen PM, 2 types of insulin, a short-acting and a long-acting, metformin, and phenytoin. With regard to her metastatic breast cancer, she's on pertuzumab, trastuzumab, and docetaxel. So why is it that she has this positive urine drug test? Well, they did do a confirmation, which we'll come to in the later part of the talk. And it turns out that the gas chromatography mass spectroscopy, the results of which you see here, turn up. The only thing different is ibuprofen and diphenhydramine. There's no PCP, there's no tricyclics, there's no THC found. And it turns out that ibuprofen is known to cause a false positive for THC on some urine drug tests, whereas diphenhydramine actually causes PCP and tricyclic false positives on urine drug screens. When it comes to false positive PCP drug screens, it is by far and away diphenhydramine is what we see here in Iowa is the most common cause of false positives for PCP. This comes into the idea of treat the patient, not the poison. We have the detection of PCP, tricyclics, and THC, but the patient isn't acting like that. And so treat what you see with the patient, not on these less than reliable lab results. And why was she weak and dizzy? Well, it turns out it was an issue with her phenytoin. She had a normal total phenytoin of 12 micrograms per milliliter, but she had very low albumin. And as phenytoin is 90% protein bound, she didn't have as much protein binding for the albumin and therefore had a free phenytoin of 3.3 with a normal being of 1 to 2. So even though her total was within the normal range of 10 to 20, her free was notably higher. So she had a positive tricyclic on the urine drug screen. Is it really a positive tricyclic? Well, here are some various things that may cross-react with it. You can see at the bottom center here, this is nortriptyline, a tricyclic antidepressant, and you'll notice the structure is just that, 3 cyclics put together. And you'll notice with the carbamazepine, the quetiapine, cyclobenzaprine, diphenhydramine, thioridazine, those have very similar structures with compared to the nortriptyline. We typically think of chemical structures as drawings like this, these nice flat, everything's laid out and very easy to take a look at. Well, back in the days when I was young, we used these stick and ball models to make these various structures, and you'll notice that this is again methamphetamine. It doesn't exactly fall nice and flat and straight, and so it's convoluted. When you actually get to some of the more fancy methods of rendering the structure, a space filling diagram, you see you have this look to it, where you can see you've got a carbon going deep into the plane of the picture, the other carbon at the bottom right coming forward, and the blue, of course, is the nitrogen. So how can it be that you wind up with these false positives? Well, ranitidine, which is now no longer available by brand name, and the generics have also been pulled off the market, you'll notice that back in this area, you've got a 5-member ring with a nitrogen and some hydrogen and hydrogens on it. Nitrogens, carbons, and hydrogens, which looks, if we could rotate it, looks a little bit like this area in methamphetamine area. So even though the structures may not look similar when they're drawn out flat, when you actually get into the 3-dimensional structure of them in vivo, there is that similarity in shape. And so it makes sense that these 5 different medications would give a false positive for tricyclics on a urine drug screen because they all have that tricyclic structure. For diphenhydramine, it only has the 2 phenyl rings, and I drew in this little red line to show how you could, easily envision there being a 3-cyclic structure to the diphenhydramine. So urine drug screens, going on to the limitations. There are hundreds, thousands, tens of thousands of websites on which you can buy urine drug screens. One that I looked at that was geared more towards the professional, either the hospital or the clinic, had 22 different brands of urine drug screens and probably another 30 saliva screens. There were, it's right there, 600, there are 22 brands with 661 urine drug screens there, 31 saliva screens, and you can see that they have various degrees of CLIA regulation. More than half of them are CLIA waived, whereas some of them, about 200 of them, get into a little more complex and therefore are CLIA regulated. What do these drug screens look at? Most of the drug screens that are out there have their package insert or their documentation available online also. And what you'll see in the next few slides is documentation from one drug screen that is available. The drug screen in question didn't necessarily cover all of the substances you see there, but all the drug screens had that capability. Drug screens can be anywhere from 1 substance all the way up to about 16. I haven't seen any more than or just 16 substances being tested at one time, but they can have a wide range of what is tested. Most frequently, you run into a 6-panel drug screen, which is usually amphetamines, opiates, PCP, THC, methamphetamine, sometimes methadone, sometimes barbiturates. So it's usually 6, but can be anywhere up to 14 to 15. And you'll notice that on the left column, you have the name of the test. In the center column, you have the calibrator. That's what the test is calibrated to. And that, as you'll see in a couple slides, doesn't necessarily mean that the test is good for other drugs or pharmaceuticals in that class. And you'll notice you also in the far right column, you have the cutoff amount concentration that the test will turn positive for. So a quick look, you'll notice under the benzodiazepines, BZO, which is down towards the middle, it's calibrated to oxazepam. And therefore, benzodiazepines that are structurally dissimilar from oxazepam may not be picked up. Likewise, when you come down into the opiates, which actually a little further up, it's calibrated to morphine. And as we'll see in a few slides, opiates that are structurally dissimilar to morphine will not get picked up by this method. Down towards the bottom, it says in bold, this assay provides only a preliminary analytical test result. All of the package inserts have a disclaimer, and in this case, it was described as the limitations. And you'll see that there are a lot of limitations that get described for these urine drug tests. It's a qualitative preliminary result. There are technical and procedural errors, some of which we'll talk about a little later on, that can cause problems with it. Adulterants can be added deliberately or unintentionally. Positive results do not indicate a level of intoxication. Do not indicate a level or intoxication. Negative results don't necessarily mean that it's a drug-free urine. It can be below the detection level, or it doesn't detect that specific drug. Also, you'll notice it doesn't distinguish between drugs of abuse and certain medications. So the person who is on dextroamphetamine for ADHD will test a urine positive for amphetamines. That urine drug test doesn't distinguish between that from the prescription dextroamphetamine from that which is purchased on the street illicitly. And lastly, at the bottom, it also mentions that there can be false positives from foods or food supplements. The amphetamine test seems to be the one that is most commonly known for having a lot of false positives associated with them. And as time goes by and the tests are refined and made better, you wind up with having different things causing false positives. So you'll see you have a laundry list of various pharmaceuticals and over-the-counters that can cause false positives or will cross-react with the amphetamine urine drug screen, but you'll notice that a couple of them have been crossed out with a light blue. And that's because one of the more recent papers that was a review of urine drug testing actually had removed those three pharmaceuticals, doxepin, ofloxacin, and venlafaxine, from their list of pharmaceuticals that can cause a false positive or a cross reaction with amphetamine urine drug screens. It was kind of interesting that 10 years ago they had those three have been removed, but interestingly, when looking at some of the other urine drug screens and articles, they actually have those three drugs still listed as potential cross-reactants. Some of these pharmaceuticals make sense they would cross-react. You have things like dextroamphetamine and ephedrine and phenylpropanolamine, chemicals that are very structurally similar to amphetamine and also have the same effect. But you also have very interesting other things on here like metformin and amantadine and selegiline and thioridazine, trazodone. Trazodone is probably one of the most common false positives that we get for amphetamines. So there's a lot of cross-reactivity. The package inserts or the literature that comes with these tests go over the specificity of the various assays that are in the test. And you'll notice here for the amphetamine specificity, the cutoff concentration is 1,000 nanograms per milliliter, and the top one, D-amphetamine, turns it positive at that level. So they call 100% cross-reactivity. But if you look towards the middle, you have L-amphetamine, the other non-active enantiomer of amphetamine. It cross-reacts with a concentration of 20,000 nanograms per milliliter. Therefore, they describe it as only having 3% cross-reactivity. You will find this with all the different assays that are in the urine drug screen. They're spelled out in detail. But if you'll notice here, all of these drugs are very similar or have similar use to amphetamine in this case. So even though you're talking about ephedrine, MDMA, methylene dioxymethamphetamine, phentermine, they're all still sympathomimetics, but even those don't all have great cross-reactivity as we described with the L-amphetamine. Methamphetamine has the same sensitivities or specificities that are listed. And interestingly, of course, it's calibrated to D-methamphetamine, but when you start looking at some of the other drugs that are similar, you'll notice that there is some cross-reactivity, and in others there isn't. But this is one specificity table that was quite interesting in that they actually had some non-sympathomimetics listed. In here you can see towards the bottom there is chloroquine and procaine a little higher up, showing their cross-reactivity. Weak cross-reactive, but in high concentrations, those can trip a false positive. One drug that's not on, ranitidine is on there, and you'll notice it also has cross-reactivity, but fairly low. Benzodiazepines, the same thing. And you'll notice that there's a long list of benzodiazepines. This is calibrated, where it is down here, with oxazepam towards the bottom. But you'll notice in the middle here, lorazepam and midazolam, two very commonly used benzodiazepines, has very low cross-reactivity. So somebody on lorazepam, even with this urine drug screen, may not be positive. Likewise, clonazepam, very commonly used benzodiazepine in the outpatients, only 38% cross-reactivity with the urine, 38% cross-reactivity with the urine drug screen. So this is where we start to get into some of the false negatives of this. The patient may be taking clonazepam or lorazepam, and they may be comatose from an overdose of clonazepam, but the urine drug screen still comes up negative. Same may also be true of lorazepam. If we move on to the opioids, in the top center we have the structure of morphine, and most of the opioid tests are calibrated to morphine. And you'll notice we have the structures of methadone, tramadol, fentanyl, and meperidine also listed, shown here. You'll notice the structures of those four are very dissimilar to that of morphine, and it is rare that you will, pretty much unheard of, where a morphine assay will pick up any of those four drugs. Because of the structural very dissimilarities between them, you can have somebody who's comatose on methadone and their opiate screen comes back negative because of this tremendous dissimilarity. Heroin is at the bottom center, and you'll notice that it's structurally very similar to morphine, and you've got those two acetyl groups in red that show the difference between morphine and heroin. Heroin is, of course, metabolized down to morphine. That's how it has its effect. The acetyl groups make it easier to penetrate the brain, which is why heroin can cause such a rapid euphoria, and then metabolize the morphine, so heroin will turn the urine drug screen positive, but the meperidine, methadone, etc. won't turn the urine drug screen positive. Even drugs, pharmaceuticals that are very similar to morphine, such as hydrocodone, hydromorphone, oxycodone, oxymorphone, may have enough similar structural differences that they may not cross-react with the morphine assay and may turn up negative for opiates. Many of the opiate assays nowadays will pick up the hydrocodone and hydromorphone, but a lot of them do have trouble with the oxycodone and oxymorphone simply because of this hydroxyl group that is right in the middle of the molecule. That is why you will see a fair number of the urine drug screens have a special test for oxycodone and hence oxymorphone. Buprenorphine, the opioid agonist that is used for treating addiction, notice how structurally dissimilar it is, and of course does not trigger the opiate positive, and usually they have their own separate buprenorphine test. And naloxone, even though it's not too different, it does have that tail coming off onto the bottom right. Even though it's not too structurally dissimilar, it's dissimilar enough that naloxone doesn't trip any of the opiate tests positive. So for the specific test of methadone, looking at just methadone or its metabolite, here's how they break down the testing, the assessment of testing at various different concentrations of methadone in the urine. Methadone cutoff is 300 nanograms per milliliter. And when you're right there at the cutoff, it's interesting to note that you have 3 different lots that were tested and all observed. In the first lot, 22 of the 50 were negative at 300 nanograms per milliliter, the cutoff. In lot 2, 25, and in lot 3, another 22. So about 50% of the urine drug tests that were tested with this specific urine drug test were negative at the cutoff value. Of course, as you get above the cutoff value, you wind up having them turn all positive. Well, and there isn't that much of a difference. You'll notice from 300 nanograms per milliliter to 375 nanograms per milliliter, it goes from 50% positive to 100% positive. But when you're right there at that cutoff range, that may not turn positive. And there, of course, you have another of the false negatives. All of the package inserts have what they describe as interfering substances. And this is the one package insert that had a long list of interfering substances. And you'll notice there are a fair number for amphetamine. There are a lot for the oxycodone assay. But interestingly, they didn't describe what the interference was. And in looking through many of these package inserts, the interference wasn't described. Yes, these chemicals will interfere, but it doesn't say how they will interfere. And interestingly, if you look under cocaine, cocaine is metabolized to benzylecgonine. So it tests for the benzylecgonine. It describes the substance it's testing for as an interference for the test. And that I could not make heads or tails of, and could not find anything discussed in the literature, and did not hear back from any of the companies that make these tests in a reasonable amount of time. So I'm not sure how you have a drug that it's supposed to detect being termed as an interfering substance, and as also mentioned, they don't describe what the interferences are. All of these package inserts do have a cross-reactivity table. And in this cross-reactivity table, towards the bottom, the last line, it says the following compounds show no cross-reactivity when tested with the test in a concentration of 100 micrograms per milliliter. Okay, that makes sense. And you see there's a fairly long list. But what about ones that we know are very good cross-reactants, like bupropion? Cross-reacts frequently with the amphetamine and methamphetamine assay, because if you look at them structurally, bupropion is a methamphetamine/amphetamine derivative. Bupropion's not listed here. We saw earlier ibuprofen can cause a false positive for THC, and that's not listed here. And diphenhydramine, which can cause a false positive TCA and PCP, is also not listed. So package insert doesn't necessarily give you all the information that you're looking for. Lastly, the package inserts will also describe urine detection time, and realizing that these are approximate values. You'll notice that they have the cutoff value listed, the minimum amount of time, so the earliest the urine is likely to turn positive, and also the maximum time that it's likely to stay positive, but there's a little bit of wiggle room in here. So for the first one, marijuana, the cutoff level of 50 nanograms per milliliter, maximum up to 5+ days. Well, they know that in people who rarely use marijuana, the cutoff may only be about 3 days. The urine will still be positive. People who are daily heavy smokers of marijuana, after being off marijuana for 20 to 30 days, their urine can still be positive for THC because of the amount of THC that's been in the fat that gets liberated into the urine over time. And as I said, can still turn those urines positive 20 to 30 days after they have stopped smoking or stopped being exposed to the THC. Under amphetamines, the detection time is maximum 2 to 4 days, but that depends on urine pH. If the urine pH is lower, more acidic, it goes out more quickly, and therefore the detection time is shorter than the 2 to 4 days. So if you're testing somebody for amphetamines and you think it was, a week ago, it's unlikely that test is going to be positive. Even if it's 2 to 3 days ago, it may not turn positive, even if they have had a true exposure because of urine changes in the urine characteristics. Likewise, somebody who is doing a urine drug test who turns up to have been off smoking marijuana for 2 weeks may be telling the truth, but if they've been a heavy smoker, their urine drug screen could still turn positive. The next case is about a man who's brought into the emergency department as described by EMS and police as being stoned. So a 19-year-old male with no past medical history who is brought in by law enforcement from a large social gathering, and he's awake, non-interactive. He's moving around and looks around, but he doesn't interact with anyone and appears to be responding to internal stimuli. And they think he's either having a psychiatric problem or he's been exposed to a drug of abuse. So they do the big workup and nothing turns up positive. And they did the urine drug screen, where, as you can see, had a lot of different things. 6-AM, 6-acetylmorphine is a heroin metabolite, amphetamines, barbiturates, bupropion, benzodiazepines, et cetera, and they're all negative. But he looks stoned. He's acting stoned. So, but the urine drug screen says it's not. Well, when they did the gas chromatography, it turned out that it was AB fubinaca that came up positive, a synthetic cannabinoid, and that can cause these type of effects. The synthetic cannabinoids that most people refer to generically as K2 or spice have a lot of different effects. All synthetic cannabinoids do not produce the same effect, but in this case, the AB fubinaca in this patient sort of gave him that detached, stoned appearance to him. The urine drug screen is negative, but it is still a drug of abuse problem. Here's another interesting case report where the person actually had a lot of lorazepam in their urine. So much lorazepam, it was so high that it caused a false negative. And as you see over in the table on the right, that when they diluted the urine, 20 times dilution and 40 times dilution, it eventually diluted the lorazepam in the urine enough that it turned the urine drug screen positive. So in this peculiar case, a very high concentration of lorazepam was somehow able to make the assay inaccurate and turned up a false negative. False negatives or contaminated urine drug screens can occur because of adulteration. You see on the left, there is a case report where they talk about somebody developing significant niacin toxicity because they had read on the internet that high doses of niacin in the urine will act as a cleanser and prevent the urine drug test from turning positive. What actually happened is the person developed niacin toxicity instead. There is a laundry list of websites that offer ways to get around urine drug testing. The one you see at the top right there sells you clean urine along with a prosthesis to deliver it if you're a male. The bottom is clean urine that is sold, is available. It says it's toxin-free, and it says, it's hard to read in that red line, it says for research and novelty use only. But of course, it's not being used for that. So adulteration can turn up a false negative. People's metabolism of these various drugs can wind up causing difference or unexpected results in a urine drug screen. One of the classics is codeine and morphine. Codeine metabolizes the morphine, and people who metabolize it very quickly can all of a sudden get a much bigger effect from the morphine than you would normally expect. Then there are drug-drug interactions, drugs that either speed up or slow the metabolism of some of these drugs of abuse may clear them out of the system clear them out more quickly, or for others, make them persist for a longer period of time. And lastly, mention about the metabolic status. Here they talk about ultra-rapid metabolizers of hydrocodone, of oxycodone and hydrocodone, and how that changes their reaction to being prescribed that drug, and how the therapeutics have to change in order for them to get effective relief from those opiates. So what can you do? You can do a comprehensive or confirmatory drug test. This wasn't one of those. This story is actually out on the internet where a urine drug screen, probably one of those cups that you saw in slide number 4, was used and tested for the various substances you see there, and the patient was charged $17,850 for a drug test that, when you're buying in bulk, can be anywhere from $3 to $8. Even the ones that test for things like K2 and fentanyl, and they're the 16 panel ones, even those are no more than $12. So being generous and say it was $17 for that test cup, there have a $1,000 or 10,000, 100,000 time markup on the amount that the patient was charged. This lab, you notice it's listed in the upper left, is since gone out of business. So how do we go about making comprehensive or confirmatory testing? This is one of the machines that's most frequently used. It's a gas chromatography mass spectrometer. The left side of the machine, where you see the circle, is the gas chromatography half. The right side, from the tower onto the right, that is the mass spectrometer. And what these do is they are very sensitive and very specific for the chemicals that they are detecting. This is the description from one of the reference labs for a urine drug screen done by GC Mass Spec. And you'll notice that in this bottom part, it talks about the different classes that are detectable: amphetamines, analgesics, and anorexics, and so on. Gas chromatography, as shown in this slide, has the different chemicals come out through a column at different rates. So the early ones that go through the column most quickly come out, as you see, the quickest here is about 7.5 minutes. Those that are different chemically come out much later. And so you can see, even though this had 10 different sympathomimetic amines being tested, run through the column at one time, they got spread out very widely. So being able to tell the difference in what these different amines are. There are different types of gas chromatography, different types of columns, different types of carrier gases, different types of derivatization. As you see on this slide, this talks about methamphetamine and amphetamine and TFAA. That's an acylation of the compounds to change how they move through the gas chromatography column. And you will see that you have different retentions, different times that it takes the amphetamine and methamphetamine to come out of the GC. So that spreading out helps determine what the chemical is. And as I said, different types of GC columns give different results. The second half of that is mass spectroscopy, where the molecule is, for some mass specs, will be bombarded with electrons and split up. And so you get these different weights of the broken up parts of the molecule. Some of them will just take a look at the weight of the entire molecule. And you'll notice we have two mass spectra here, one for amphetamine and the other for methamphetamine. And even though they are structurally very similar, you'll notice that they have very different mass spectroscopy. So they have different gas chromatography results and different mass spectroscopy results. And so that's what makes these very specific for being able to determine what is actually in the sample. So even though amphetamine and methamphetamine are similar and may give you false positives for one or the other in a urine drug screen, that does not happen with gas chromatography mass spectroscopy. Another test that may be done is infrared spectroscopy. It's usually combined with gas chromatography, and you'll notice that even though amphetamine and methamphetamine are similar, their infrared spectra are notably different. On the left-hand side of amphetamine, you've got two big peaks, or two separated peaks, each of which has two little peaks, whereas on the left side of methamphetamine, you just have that one big peak going down. So this can also help be very accurate about distinguishing what these different chemicals are. So how do the reference labs run these tests? Yes, you could order the GC mass spec straight away, but of course it's going to cost a lot of money. The one test, or the one lab I mentioned earlier, what they do is they will actually, if you go down this pathway, is order a screening ELISA. So the urine drug screen that we just talked about earlier, the cups, the dipsticks, the cassettes. And if any of those turn positive, they will then do the gas chromatography to confirm what's there or not. So they will still get false positives and false negatives out of the urine drug screen, but they have the equipment there to do the confirmatory testing with GC mass spec. If you were to order that urine drug screen of GC mass spec straight off, it will detect these 236 different chemicals, and I know they're way too small for you to read, +1. And the +1 is other findings. And a good lab, when they're running GC mass spec, if they find something that's there that doesn't line up with what they're expecting, or they can't, it's not in their library, or under the group that they're looking at in their library, like drugs of abuse, they will say, we have found something else, and given the rest of our GC mass spec library, it may be X, Y, or Z. But they will also tell you that there's something there that they're not sure of what it is and can't determine what it is. So yes, you will get those 236 chemicals, pharmaceuticals looked for, but they will also give you a reading as to if there's anything else unusual there. What does this all come down to? When you're dealing with urine drug screens, it's important to have somebody who is experienced in interpreting them. Most of the time when you have urine drug screening being done for work purposes, they will have a program set up. The Department of Transportation has a very specific program that they use for drug testing of drivers. A lot of the other industries that have drug testing will follow either the DOT method, or they will use the SAMHSA, SAMHSA, the guide that you see on the left there. They'll follow one of those two basic frameworks for how they do workplace drug testing, and they all have a medical review officer. You'll notice in the top right, you have the Medical Review Officer Certification Council. If you are going to have somebody in a urine drug testing program, it's best to have somebody who has passed the certification. They have to go through continuing education every year to maintain their certification, and you can see there the various manuals that are part of the becoming certified as a medical review officer. It's the medical review officer's job to take a look at these urine tests, to know what cross-reacts as false positives, know what can give a false negative, and then be able to talk with the patient, know what they, what medications they're on, what they might be taking that may cross-react, and if the need be, then send it on for gas chromatography, mass spectroscopy. So it can be, as you can see, fairly complicated. There are several good review papers that talk about what will cross-react positive with a lot of the urine drug screens. Now, some of the things that are on there may have only been 1 or 2 case reports, and it may have been a while ago. So the technology may have improved where that won't necessarily cause a false positive, but it's important to have that background to know what you're looking at. Lastly, the package insert, the documentation that comes with these urine drug screens may not give you the entire picture. As I already mentioned, doesn't describe, the one I looked at did not, or I was discussing, did not describe how the different chemicals interfered, and it also didn't have some things listed as that are known interference. So that brings to the end, and we have a few minutes if there are any questions.
I don't see any questions that have been typed in yet. So if anybody has a question, you're free to type it in now.
And if there are any questions that occur afterwards, they do have my contact information, and you can get a hold of me through either the Continuing Education Office at Mary Greeley or through the Poison Center here in Iowa.
Doesn't look like we have any questions.
All right. Well, I thank you all for your attention, and I hope this went well as your inaugural virtual Grand Rounds. I've definitely enjoyed it, and hope you did too. Thank you.